Thank you very much indeed for the invitation to join your conference today. As you can tell, I'm very, very pleased to be in Dublin, but as you can tell, I don't come from around here. I come from Cork. I knew that my mission to Ireland was successful much more quickly than I expected, because it was only 4 or 5 months after I moved to the UCC that I was walking down the corridor and somebody said, "Hey up, lad." We're trying very hard, of course, to help people understand the Yorkshire accent much more clearly. However, on a serious note, if some of what I'm saying is not completely understood, just stick your hands up and I'll try again. Of course, being in Ireland, the first thing that you all need to know is, who am I and why am I here? I mean, it's wonderful to be a professor of general practice, but the people who've been working with me in my practice for the last 25 years still can't quite believe it, because I am really a general practitioner. So what do I hope that I can bring to the conference? I've had a long-standing interest in epilepsy, not because I'm a specialist, not because I know more than anybody else about it, but because it seemed to me when I first started in general practice in 1932, that was a joke, that really I was very similar to a lot of general practitioners and frankly a lot of hospital doctors, that we didn't really understand epilepsy, and so we kind of avoided it, or we just sort of rushed people back into the hospital system. Referral and neglect, it was the way that somebody described care of epilepsy in the 1980s, 1990s. And a colleague of mine who I knew when we were working for a couple of years in Canada quite a while ago, he was writing a book for GPs on the management of epilepsy and said, "I'd like you to help me write that book because I know that you don't know anything at all about the condition, and I don't want to be writing the book for myself. I want to be writing the book for people that don't know anything about the condition." So the main reason I'm here is because I know absolutely nothing. It's up to you to decide whether in the last 20 years I have learnt anything. So we published a book for general practitioners nearly 20 years ago now. As a result of that, I did some pretty poor research on educational needs for general practitioners, and then found that I had to learn more about it, so I went back to university part-time to do a master's. And then I was asked by Jane Hanna, who is the chief exec of a wonderful charity in the UK on sudden death and epilepsy. She lost her fiancé from sudden death in the early 90s. She asked if I would help with what was called the National Sentinel Clinical Audit on Epilepsy-Related Death. That meant that it was a UK-based audit, so it was Wales, Scotland, Northern Ireland and England. And we tried to identify about 250 cases of people who died probably from sudden death and epilepsy, and look at the care that they had in their time leading up to death, and seeing if any of those deaths may have been preventable. I led the primary care arm, and we had a structure to examine the case notes in general practice, just as we had a template to examine the case notes in hospital. And I looked at the results after the audit officers had been collecting data for about 18 months, and there was very, very little data to analyze because nobody wrote anything down. In other words, there was very little care for epilepsy in general practice. Perhaps only reassuring for my professional pride was when we were looking at the hospital notes were equally fragmented. But we worked out that somewhere between 25 and 40% of deaths were perhaps preventable. Now, at last, people started to listen to epilepsy, started to listen to the problems that epilepsy donates to those individuals with the condition of which many of you in the room today will experience. And of course, as Aidan said, epilepsy is not a diagnosis. It is just an umbrella term for any number of different ways that the brain is essentially overstimulated, and the electrics sometimes get a little bit cross-wired. So then I was asked to chair the NICE, the National Institute for Health and Clinical Excellence, the Guideline Development Group on Epilepsies. And so I was in a room of 20 people, most of whom worked at Great Ormond Street or the Institute of Neurology or wherever. And so we also had 4 people with epilepsy or representing charities on that guidelines group. And after 2 years, we presented the first epilepsy guideline in 2004. And it's a piece of work, I think, that has stood the test of time. It's been updated in 2012. But does seem, from what I hear from my friends and colleagues in Australia, in Canada, in America, and in the Netherlands, that it is embraced. But I think the most important and the most interesting piece of work is that I was invited onto the scientific advisory board, in other words, a group of us, who are looking at data in what is called a prospective observational study. In other words, we set off looking at something and collect data as the years progress. And the UK and Ireland Epilepsy and Pregnancy Register started in 94, 95, something there, and gradually has collected data from women with epilepsy who've become pregnant, and about the outcome of that pregnancy have been recorded. We've now got about 8,000 to 8,300 cases, which is the biggest collection of cases in the world. America have got a register, but it isn't as large as that. There is a European register, but theirs is a very complicated data collection tool, so their completed registrations are, in fact, less than the UK and Ireland register. And perhaps we can talk a little bit about that in questions and answers. I know there are 1 or 2 problems that are causing concern, but it does show give us some indication about what are relatively safe and relatively less safe medications for women in pregnancies. People tell me, well, of course, yes, one of the most important things, of course, caring for people with epilepsy, doctor, is that you should ensure that women have preconceptual counselling. And I say, yes, indeed. And I have never met a woman yet in my practice who hasn't asked permission before they come pregnant. It always seems to be an afterthought, if you see what I mean. So we should really start to give that sort of information to girls with epilepsy. Well, it depends which part of the country you're in, it depends who you're talking to, but probably when they're 12 or 14 or 16, so that they have that information that they can use. I now do some research into self-management of epilepsy. That's how people with epilepsy manage their lives and themselves. So life beyond epilepsy. In other words, what is that life apart from your seizures? And I'm currently very proud to be working with the charity Sued Action. It used to be called Epilepsy Bereaved, who have linked with Epilepsy Ireland to, and we started a register of epilepsy-related death in March 2013. We'll talk a little bit about epilepsy death at the end of the talk, not to concern or frighten anybody, but to show that if we embrace this as a particular problem, there are ways of reducing that risk. And so if anybody here dares to listen to this lecture and then go away and die, you'll have me to cope with. Because what I'm going to try and do is give you the information that can reduce that risk. So I come from Yorkshire. I did my medicine in Scotland, and I have worked in Canada, but actually I come from Yorkshire. And for about 100 years, I practiced in a lovely country practice and that was me taking a picture on my way back from a visit. On that track there, leads past the Yorkshire Gents cricket ground as well, but Vincent. And then when I went to Sheffield to start doing the university stuff about 5 or 6 years ago, I worked in a very deprived council area in downtown Sheffield. But I remember that the first president of the College of GPs in the UK, a fellow called Will Pickles, who was a GP in a glorious part of the world. Now, I happen to live very near to Cork. The reason that I live there, well, I've got a job there, okay. But the reason that I live there is that we're sort of on the edge of the city because at the weekends we can escape to West Cork. Now, guys and gals, you live in one of the most beautiful parts of the world. But will you kindly keep it to yourselves because we're getting more and more people who are visiting from elsewhere in the world and they're making the roads too busy. So I'd like you, if you wouldn't mind, just to keep it a secret. But Will Pickles practiced in Wensleydale, which is another beautiful part of the world, in God's own county, Yorkshire. That was a fact. And he said, talking about general practice and general practitioners, and he's absolutely right, he said our observations are direct and the contact is human. We often supply facts that no other member of the profession can. We see disease in its early stage, very rarely the chance of the specialist, and we can follow it from the beginning to the end of the illness. So at its very best, we as general practitioners can try and understand the progress and the impact and the management and the treatment of conditions. But, ladies and gentlemen, we can only do it if we work absolutely in partnership with our patients. So I'm going to talk more on the one-to-one, the individual basis, rather than the international epidemiological basis. So, what is the ideal? When you go to see your GP for an annual review, and I know that is not very common in Ireland, because in Ireland the system is that neurologists try very hard to see everybody for review however often. That's why we know that the clinics up and down the country are full, and that access to those clinics is difficult. What I suggest to you is that if you're going to see your GP, it may be worthwhile asking them just to review your epilepsy at the same time. The general practitioner may look a little bit scared by this, but you can help him or her how to do it better. And the structured review is something that we worked out. Check that it is epilepsy. Check that your seizures haven't changed, the feel of them, the description of them hasn't changed. Discuss with the GP your treatment and your happiness or concern about that treatment. And please be honest and tell us how you take that medication. We know what's written on the prescription. We know what's written on the label of the box. But it's more interesting, it's more vital for us to know actually how you really use the medication. We want to know what information you have and what information gaps you have. Not that we can tell you in the surgery, but we can certainly signpost you to some excellent advice from reputable organisations such as Epilepsy Ireland. We can also ask if you're happy with your educational status, if you're at school, if you're happy with your driving licence, if you're a woman, if you're considering pregnancy, and please don't take that the wrong way. If you're older and you've had one of the brain conditions that happens with age, a stroke perhaps, and some funny things are happening, to discuss it with us. And then general practitioners are getting some advice about when we should refer people back to neurology clinics and when indeed things are pretty stable. That's in its very early stages and something that I'm hoping to be able to help Dr. Doherty, the care programme director in Ireland with. So let's now look and see how epilepsy affects you. I don't know how your epilepsy affects you as an individual. So that's one of the reasons why I'm very pleased to be here, because I'm going to be learning an awful lot in the workshops from what you're saying. I hope I'm going to learn a little bit from some of the questions that you may want to ask at the end of the morning session. Okay, do you remember the day when you were happy, smiling, life was sunny, and you had hopes? What am I going to do when I grow up? I'm going to be a lorry driver. I'm going to cruise Highway 49. Yes, and I'm going to have fun. I'm going to play games. I'm going to swim, and of course, one day I may get into a relationship either with Franz Klammer or perhaps Betty McDonald. But life's good. Okay, and then you have a seizure. Silly of you. Shouldn't have done that, because it does kind of have an effect, doesn't it? So I suspect that it affects absolutely every last part of your life, your thinking and what you can and can't do. So the challenges that I've heard of are, of course, that it's horrible to have epilepsy, and it's not really something that you go boasting about to everybody else. Aidan's talked about stigma. Another of the problems is access to medical care. Aidan's talked about the treatment gap with the world population in epilepsy. I also talk about the treatment gap in this country, where anti-epileptic drugs are available, but for some reason, probably because we haven't explored exactly what tablets and the condition mean to somebody, people will choose not to take that medication in the way that they're prescribed, and therefore I would suggest that's a treatment gap as well. Living with the condition, there is so much misunderstanding, so much labeling that goes on at work, with your friends, also with your medical and nursing professionals, that you need to know a lot about what's going on with the condition so that you can help inform the general public. And you can share the decisions that are made about your epilepsy. One of the challenges is medicine's adherence. That's the latest way of essentially saying, how do you take your medicines? And of course, there is the perverse incentive of somebody with epilepsy, when something goes wrong, when you have a seizure after a long, long time, the perverse incentive of telling somebody about it, because what do I do? Oh, thanks for letting me know. Oh, by the way, you cannot do A, B, C. So of course we know that self-report of seizure change is very much an underreport, because there is no incentive to report it. Albert Schweitzer came from Germany, did a lot of really good work in the developing world. And he said this, I think, in about the 1930s. Each patient carries their own doctor inside themselves. They come to us as doctors not knowing that truth. And we are at our best when we give the doctor that resides within each patient a chance to go to work. So we need your help to get the thing right. Every patient carries their doctor within inside themselves. However, when you go and see a physician, you sometimes feel that perhaps the consultation is narrowed down to the biomedical model, and it is really difficult to discuss things that you'd really like to discuss if the arguments are too narrow. There's also another one of him on a racing bike saying we often don't use all our gears, but I couldn't find that one. So let's talk about self-management. We're talking about reducing risk. It is how you as an individual make decisions about your life and your epilepsy. There was somebody who wrote a book about this. Now, it seems to me that the best books are, in fact, books on common sense. patients with chronic conditions make day-to-day decisions about or how to self-manage their illnesses? No. Heavens, what a surprise. It's just that those decisions and the attitudes and influences for those decisions are very rarely discussed with your health professionals. So somebody called Kate Lorig in Stanford University in the USA invented this. She called it a patient-professional partnership, a new paradigm. In other words, can the patient work with the doctor? Now, perhaps I'm just not a very good doctor. Perhaps I'm not very bright. Perhaps, you see, general practitioners aren't anything like as bright as specialists, are they, Aidan? I mean, we're not. Because we only do general practice because we can't be a neurologist. Actually, not at all true, but thank you, Aidan, for being a neurologist. Somebody has to. But coming from UCC, Aidan, of course, has had some of the best training in the Western world. Ever since I started in general practice, I couldn't think about how I would work as a GP, how I would consult with patients, if I didn't ask what was going on with you. It seems to me that that's absolutely how we work, but apparently it's a new paradigm. So, we talk about how people optimally manage themselves and their condition by information, knowledge, and skills. In other words, what do you need to know? How is it affecting you? What is important for you? And Corbin and Strauss 20, 25 years ago discussed how people care for their disease. I hate the word disease, we'll talk about that in a minute. How to work and maintain as normal a life as possible, but also the emotional stresses and strains and changes that go on when we have what we call a long-term condition. That there is the phrase that's very commonly used in Ireland and the US is a chronic disease. Now you're looking at a diseased individual. I am a diseased individual, okay? I have high blood pressure. Well, it's only because I'm nervous. But I hope I don't all the time because I now take tablets. But apparently I thought I would just, oh darn, it's a nuisance, I've got to take tablets. But no, I've got a chronic disease. I think it's very important for epilepsy to be regarded as a bloody nuisance long-term condition rather than a disease. If we have a disease, it's almost as though it's something that has been imported to us and we can't do anything about it. What do we do with a diseased, if we have a shrub with a diseased bit on, we cut it off? Well, in a way, I think that that's the wrong concept. However, there is a contrary argument to say that it's actually the best way to look at it in terms of treatment, investigation, and healthcare delivery, because it means that it's a big problem. But I like to talk about long-term conditions. So, because I'm a professor, I write papers, and I'm not sure I write as many as Aidan, but there was a community-based study that we did from my general practice. It was a country practice. We had 4,000 or 5,000 patients. There were 3 doctors, and we were a research practice. We had a massive research team in the practice. There was me, because I did research on Thursday afternoons, and there was Debbie, who was my research assistant, and she was there 3 days a week. So the massive community epilepsy research team was me half a day a week and Debbie. But what we did, we questionnared over 300 patients with epilepsy, having found them from the clinical records of 30 general practices in God's own county. And we looked at 1,333 records, and we found out of that there were about 500 people who had a strong diagnosis of epilepsy. The others either didn't or were given the medication for other reasons. And we questionnared those people, and we got a remarkably good response rate. And I asked 1 or 2 people who I met who'd filled in the questionnaire, and they said, We get a lot of questionnaires through the post, and a lot of it is a waste of time. It doesn't seem that it's going to make any difference to us. But we are very happy to help with research that we feel will make a difference and address something that we don't feel has been addressed in the past. We looked at how people took their medication, we looked at their epilepsy, but we also used a questionnaire developed by a wonderful team over in South Carolina, I think, Colin Diorio and Jan Bulow. And they have a questionnaire, questions looking at how we manage ourselves with whatever condition. But they developed it for epilepsy, the Epilepsy Self-Management Score. And low self-management scores, in other words, people doing things or taking decisions that could be risky, were associated with a young age. Okay, so teenagers and young adults are probably less wise than people of my age. I wouldn't necessarily take that as the case. But we also found that low self-management scores, surprisingly, were in people who were in education or were in employment. In other words, who were functioning quite well. But they, I guess, were making decisions about their treatment and about their lives because they thought they knew best. Low self-management scores with from people who were living with others. In other words, sometimes people kind of left the management to their spouses, to their family. And also, perhaps not unsurprisingly, those who had had recent seizures. So what information do you need as somebody with epilepsy? It's written down there. The epilepsy information is available. Get it from good sources, get it from respected charities. But you should know about your epilepsy, you should know about what sort of seizures you have, you should know about the treatment open to you, the options open to you, and also the treatment that you're taking, whether or not it's suiting you, but also how you live your lives. Particularly women of childbearing age, talk to your doctor about your medication, please, if you can, before you get pregnant. How you stay safe, what support is available, and of course not just preconceptual planning, but there is some issues about contraception when you're pregnant, breastfeeding, and also the menopause can lead to problems. So how does a condition impact an individual? Okay, we get ill. I've been really ill this last couple of days. It's been awful. I've had a cough. No, I mean a cough. So what did I do? I tried to interpret this cough. Oh dear, this is very bad. I'm going to have a word with Wendy. I'm going to have to cancel the conference on Saturday. And then my wife said, oh, for goodness sake, just blow your nose. So we make some sort of perception of the symptoms, of the social messages. So is this cough very important? No, not at all. In fact, you've noticed that I've managed to suppress this desperately serious cough for the last 25 minutes. And is this sort of cough normal? In other words, have I got a bit of a cold and have I had this cough? And is it kind of what everybody else, well, it's more severe, of course, than what everybody else gets, but it's kind of the same. So we also look at whether it is kind of within the normal range or not. Now, so on the physical side, on the objective side, so our health psychology colleagues tell us, this is a fellow called Leventhal that wrote this, he says, we look at the representation of the health threat. What is the identity? In other words, what have we got? What's caused it? What are the consequences? When's it going to get better or worse? And is there a cure or a control? So if I have the cough with a snotty nose, sorry, that's Yorkshire for a mucopurulent discharge from the nasal passage. Okay, so the representation of that health threat is, apart from me, it is actually low. It is not really a health threat. But what if I cough for another 4 or 5 days and the cough in the morning becomes bloody? and I start to cough blood. Now, I don't smoke, but oh wow, did I? It was, do you remember in those days when it wasn't really seen as being harmful, and you could actually have a Hamlet cigar with a pint in the pub, and nobody would say anything. Oh, it was absolutely marvellous, but everything changed about 25, 30 years ago. The only time that I wanted to start smoking again was when that law came out saying that I couldn't. But I'd run out of money, so I couldn't buy any. But if I cough blood, then the representation of that health threat, of course, changes. That this is not a bit of a snotty nose and a bit of a wimp of a fellow. This could be a cancer of the lung, okay? So, does that work? So how do I cope with it? Well, at the moment I blow my nose and I'm very brave and I'm standing up in front of 100 people. How do I avoid it in the future? I might have a flu jab, or I might decide not to come to Dublin again because obviously it's full of viruses. And to stay down in Cork, where frankly I haven't yet met a virus. It's probably because of the high quality of the food, the natural homegrown food that you get down there. It builds your immunity. But of course, with any health perception of illness, we also have an emotional response. And there is fear, there is anxiety, there's depression, there's also pressure. So it's a dual feedback system, the physical bit and the emotional bit. So if I was 22 years of age and I was sitting a final exam tomorrow at the university, then my fear that the health threat would be more serious than it is at the moment, it would be magnified. So of course it's all right for you to bring the representation or the description of epilepsy to us as doctors by knowing that there's both the physical and the psychological balance. Self-efficacy, I just love this slide. This means, what can I do to control this problem? I particularly like the one with the cat, because I think all of us who've got cats have got cats that would do exactly that. Say, call yourself tough, I am in control. Self-efficacy is how much you are in control of your epilepsy rather than me or specialists or nurses or the health system or whatever. In other words, how do I manage to control it? The biggest risk to having recurrent seizures, the biggest risk factor that we've found in our work looking at people who've died of epilepsy is because for some reason people have chosen to take their medication not in the way that has been prescribed. This is called medicine's non-adherence, that somebody has decided not to adhere with the agreement of the treatment between the prescriber and the patient. So that's what it is. Is it common? I want you to put your hands up when you think of, out of 100% would be everybody takes all their medicine, whatever medicines it is, as prescribed. So of course we know that it isn't 100%. Studies have shown that there is a percentage of non-adherence. So hands up, those who think it might be 10%. 20%? Thank you. 30%? Thank you. 43%? 50%? It's between 30 and 50%, we think. But with some medications... What?
Partly three.
Well, that was the one I did. But depending on the condition, depending on the medicine, half of the prescriptions for epilepsy are not taken in the way that we think would work best. Now, that doesn't mean to say, tut, 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 you are very naughty, you should take their medication. But it does mean that as a doctor, I should be saying to people, are you content with this prescription? Is this the way that you can take and use your medicine? Or if not, will you tell me so we can negotiate that? Because there's no point me thinking that you're taking this and you're actually taking that. Medicine's adherence, the decisions about medicine are all to do with the balance of how necessary people feel that the drug is and how many and what concerns there are about taking it. Non-adherence is common, but it's also dynamic. So there isn't one group of people here who are non-adherent, never take their medicine as prescribed, and the others who always do, because over a period of time, situations change. So everybody at times will take their medicine as they should. Everybody at times may not. So when I talk to GPs, I say there is a bit of a checklist, just a few questions you can ask people just to see how it's working. And of course, if you're really clever and you're a professor at UCC, you use something called a medicine's possession ratio to see from the prescription records how many people are likely to be non-adherent. Non-adherence can be intentional. In other words, people can make a decision that actually they don't want to take the pills as often as prescribed, influenced by beliefs, influenced by concerns and necessity. Can, of course, be unintentional. When you get to my age and you're on blood pressure medication, you just blinking well forget sometimes. I mean, really. I'm very bright, but I'm hopeless at remembering my tablets. So what I've done is my doctor said, you are on an ACE inhibitor, you're on lisinopril, you only need to take them once a day, that will help you take them. No, actually it doesn't, because if I forget them in the morning, I don't remember until the next morning, and then it's 24 hours without. So what I've done is I've said, no, actually instead of 20 milligrams of lisinopril first thing in the morning, could I have 10 milligrams twice a day, because then I'll take them in the morning and at night, and if I've forgotten in the morning, I can take them both at night. So then, do you see what I mean? But I'm probably a difficult patient. Well, heck, I hope I am. So there could be difficulties understanding the instructions and the reasons for taking them. Or of course, some people can't quite reach or open the pill bottle. In some countries, it's that people can't afford to pay for the medication, so you've got to make some sort of economic negotiation with yourself about what are and are not important. So we looked at a group of patients, some of whom seemed to take their medicines as prescribed, some who didn't. In other words, an adherent and a non-adherent population with epilepsy. And we found that you could work out those at risk, and also the best way of dealing with this was not for the doctor to say, oh, okay, yes, I see that you haven't been taking the medication that I said you should take. Ha! Because that could be perceived as being judgmental. So what we have to do, the approach has got to be, okay, tell me how you're using them, tell me the reasons why. We found that over half people would prefer not to take anti-epileptic drugs than to have the occasional seizure, as long as you got away with it. Now, that's interesting, because when you talk face-to-face with people, nobody really wants to admit to that. But we found that over a third of people had concerns about taking long-term anti-epileptic drugs. For those of you in the room who take AEDs, there is no worry about taking them long-term. Essentially, that shows people's attitudes about their medicine. Did they think it was very important or not? And only 55% thought that without their epilepsy medication they would become ill. That's even worse, okay, so obviously this study is a massively complex study, but nearly 50% of the respondents worry about the long-term effects of epilepsy medication. Only 20% said that the epilepsy medication could cause unpleasant side effects. There was a thinking which is wrong, that non-adherence was mainly because of side effects. That actually isn't the case. Nearly a third of people felt that taking medicine labeled them as being an epileptic, a horrible label. And so we looked at concerns, high or low, low or high necessity of taking medication. And it is published, but again, of course, it doesn't take a genius to know that if we discuss your concerns about the medication, point out the necessity of taking the medication, you can make that decision yourselves. So please be involved in decisions taken about your care. Lastly, sudden unexpected death in epilepsy. We've collected data from about 350 deaths since March 2013 on an online register. It was started off in the UK, but we've got, I think, about 15 or 20% of our registrations come from North America. About 5 or 10% come from Australia. And shortly, we would really like your contribution to set up the Epilepsy Deaths Register of Ireland. Why are we doing this? It is to try and make some sense of the crushing tragedy that happens in families if somebody dies as a result of epilepsy. It is also, in a way, to get rid of some of the nonsense that's talked about, yes, well, epilepsy is not very serious and you never die from it. When my daughter was at a first aid class, she's now a rather disagreeable 20-something-year-old who's got a medical degree. She keeps telling me that I don't know what I'm talking about. I find this quite disgraceful because I tried to bring her up knowing that everything I said was completely true. When she was doing a first aid course when she was about 15, the guy said, oh yeah, and then we come to epilepsy. Well, epileptics, he said, epileptics, they have seizures sometimes. He said, and you turn them on their side, make sure the airway is clear. He said, but at least nobody dies of it. And my daughter said, excuse me, they do? No, they don't. They don't die of epilepsy. And he read the book. Yes, they do. No, it's down here. Why do you say they do? Well, I don't know, but my dad says they do. Well, who's your dad? He's a doctor. Oh. We don't know how many people die of sudden unexpected death in epilepsy. We don't know how many deaths are related to epilepsy because the only way that we know is if coroners and medical examiners in the States, the problem is the same internationally. How many cases of death are truly attributed to the cause of death? SUDEP is something that many coroners are rather fearful about using because they don't really understand it. But there's been a lot of work done, mainly in North America, about this over the last 2 or 3 years. And now there is something that is called definite SUDEP. Post-mortem results, circumstances all point to definitely this person died of SUDEP. And then there is probable SUDEP, most likely, but perhaps a post-mortem hasn't been done. And then there is possible SUDEP, not sure, but it might have been. Why do we need information? Because a lot of SUDEP, I think, is caused by people taking wrong decisions about their epilepsy and their treatment. I work with a remarkable group of bereaved families, mainly from the UK, but I have met families in America as well with this. And they say that if we had known about the potential risks, we would have, or our beloved one may have made different decisions about their medication. Please get the information. Please talk to your doctors about this. Talk to your families about this. And please, if you're making any decisions about your medicine, talk to us first, but please express all your concerns so you can make some sort of balance. Thank you.